All right, we're gonna turn on and waiting to see, we've got a few people starting to get in here, so we'll give them a minute. Good evening, this is Ellen Teeter. I'm the Executive Director of FSOMA, and I have David Bibby with me. He's the Vice President of FSOMA and been leading our legislative work this year. So there is a chat box down in the middle to right lower corner of your screen. It should be, it's a little round talking kind of icon that says chat. That's how we're going to take questions. So if you can open that up, and if you want to tell me who's here, that'd be great. But we've got the, that's how we're going to take questions today, is with the chat box. And if I can break in with a question, I'm going to moderate this and let David know. So that is what's going on. So first, I'm going to talk a little bit about Medicare. So let me share a PowerPoint with you. I think a lot of people got the word that Medicare is now covering acupuncture, and that's great news. The up to 20 visits will be allowed per year, with 12 visits in the first 90 days. Has to show improvement, so you'll need to keep good medical records. There is a webinar coming up on medical records shortly, so look for information on that. Only a physician can do this, or someone who with a I'm sorry, I got off that slide, with a master's or doctoral level. So they've actually put the definition of our training in there to, you know, if you're accredited. So this prevents people with less than standard training from getting benefits. Unfortunately, right now, it's still requiring supervision, and we're included as adjuncts. We're not named as licensed acupuncturists, but it does say that other practitioners, nurse practitioners, clinical nurse specialists, physicians assistants, to practice acupuncture, they've got to have the training that we have. So this is some good news for us. And we're in there, but we do have to have a referral or supervision from a medical doctor until we can get ourselves into statute as a provider. And the good news is we are in the Bureau of Labor Statistics as a profession. The Congress is going to have to add us to the provider list for Medicare in order for us to directly bill. So it's a step in the right direction. It's also a very good step that they are requiring anybody who's going to practice acupuncture, except for the medical doctors, anybody that's practicing it, to have our level of training, to have ACOM training. And they've defined dry needling as a type of acupuncture. So that that's a very helpful thing as well. David, do you have anything to add on this?
No, I think it's a welcome opportunity for us to, you know, move into an integrated scheme with providing treatment in physicians' offices is probably the most likely scheme. I think it's also beneficial that, since acupuncturists, unless they're trained in another medical discipline, if they were a medical doctor in a previous life or worked in a Medicare provider's office, they may be more familiar with the documentation requirements for Medicare, as well as the systems for reporting and assessing patients through Medicare. So I think this is a good first step for us to have an opportunity to move into a teaching and learning environment under supervision to develop those skills necessary to sort of mature as providers and ultimately provide independent care. But I think this is a really fantastic first step.
Okay. The next step is working nationally to have the ACOM accredited acupuncturists inserted into statutory language. Representative Judy Chu has had the bill Acupuncture for Heroes and Seniors pending for several years, and we now have a sponsor for it in the US Senate. So this is one route that is already in process. So we need to look for some, get some more sponsors for the bill. That's one thing we can talk to our US representatives and senators about, and also ask your US representative and senator to support this. Our help for people with opioid addiction and to prevent people from even having to use them is crucial. I think it's something that's really missing from the modern healthcare system. So, so these are some steps, and we'll try to put some links up on the legislative page in the next week to how to support that national. But we've got some links already up for some Florida legislative questions. I don't see any questions in the chat yet, so I'm going to go to the next slide. And David's going to start talking about dry needling bills in the House and Senate and a bill on titling. And here is the first slide on that. So David, take it away.
Okay. As Ellen was saying, there are two bills that were sponsored, one in the House, one in the Senate, that are sort of modernization bills for the Physical Therapy Practice Act. And there are a number of changes provided for in both versions in the House and in the Senate. And the changes that are being sought with the bills go well beyond dry needling, but dry needling is, of course, the part that we're trying to provide input for both in the House and in the Senate. Primarily, let's just describe the House bill first, is House Bill 457. Again, I mentioned that there's a number of changes that are being proposed for the Physical Therapy Practice Act, which have to do with things like definition for the practice of physical therapy and a handful of other broader changes that they're making to their Practice Act that have nothing to do with dry needling. But as the bill relates to dry needling in the House, what the bill provides for is a expansion of the powers of duties of the Board of Physical Therapy. And what's articulated specifically is that the board is going to have greater power to create or modify rules and minimum standards of practice for physical therapy. And included under that specifically is the ability to establish or create a rule to develop minimum standards of practice for dry needling for physical therapists. So what that bill does is not articulate definitions and standards of practice in the bill, which is typically what we see with expansion of scope bills or amendments. This instead sidesteps that question entirely and provides greater power to the Board of Physical Therapy to do that themselves. That, in our opinion, is really the most, the least advantageous way for that to come about. You know, the Board of Physical Therapy, you know, is basically a regulatory body that should, you know, in our opinion, should not be in a position to create minimum standards of training and definitions for things that it also regulates, when it squarely is part of an expansion of scope. Typically, the way that's done is that the legislature will create a framework to either approve or not approve an expansion of scope of practice to do things that historically were never included in the practice, and they provide the boundaries for that, basically definitions, some minimum standards, and then the board can later enact or promulgate rules to clarify things that are left ambiguous in the statute. But you don't just wholesale give that responsibility to the board. So we're working, when I say we, I'd say the FAA, FSOMA, and our respective lobbyists are working to find partners in the legislature on the House side that are willing to sponsor an amendment that at least provides a definition for dry needling, which will provide some boundaries for dry needling that clearly separate the performance of dry needling from the practice and the entire practice of acupuncture, as well as performing acupuncture and other invasive treatments that we use. So far, there's nobody stepping up in the House willing to sponsor an amendment to that bill to provide more clarification. And frankly, the feedback we're getting from representatives in the House, as well as from our lobbyists, and those conversations are really unproductive in that there's very little appetite in the House, not specifically regarding acupuncture or physical therapists, but they are anti-prescription, if you would, in terms of telling professions what they should do, whether it's in the insurance realm, whether it's in the home inspection realm, or as this case, it's in the healthcare realm. They basically say, hey, you know what, professionals, they're trained, they're licensed, they know what they can and can't do. Let the board just provide them with some boundaries for this. And if they do something they shouldn't do, there's ways to discipline them down the road. They really have a very, very, very laid back attitude about how professionals are going to be policed, if you would, by statute or rule. So that's the state of affairs in the House. The Senate, we worked with Senator Albritton, who sponsored that bill, along with Senator Harrell, and we do have an amendment that's been developed and adopted to the original bill. And the original bill mirrored the one in the House. So we've had progress on the Senate side, where at least they're working on establishing a definition for dry needling that has some, 4 corners to it, and some minimum standards of training that address hours, as well as a few other things that are incidental to that. The language is available. We can, provide you with a link if you want to see the full text. The amendment that was accepted in the House was accepted through the Health Policy Committee under the condition that it was a working copy, and that the physical therapists and the acupuncturists, with our respective representatives, would remain at the table working at language that was mutually agreeable. So the headache that we have with that whole process is that when we provide a definition for dry needling that I know to be accurate and to be concise, it's being rejected as overly prescriptive. In other words, they want a looser definition for dry needling, which should not be necessary, because dry needling is trigger point acupuncture is a very, straightforward and finite procedure that's easily defined. And so we've provided them with what I say is an accurate and concise definition. Right now, we're struggling with getting them to see things our way in this matter. And the bill still has 2 more committees to pass through on the Senate side. So we're working this week and next week with the Banking and Insurance Committee, who's going to hear that bill, working with their chair and members to understand our concerns about the language as it exists now. So if I zoom out a little bit and just take a recap of all of that, typically when a bill is introduced in the first year, it has some natural headwind that makes it difficult for it to get enough support to make it through all of its committees, to make it to a full vote on the floor and pass in the first year. There's a natural headwind to that process. And this bill is going to face some headwind as well. And our job is just to highlight what we think is the weaknesses in the bill, in the language, and highlight what we think are some of the public safety issues related to the minimum standards of training. And we'll just, it's a process. We just have to continue working at it as hard as we can. And like I say, the amendment language is available. We'll put up a link for it if anybody wants to see that. AccuEd Day is next week. It's an opportunity for the profession and interns to be available in Tallahassee to educate and make a personal appearance to meet with their local legislator and discuss our concerns as a profession. So we're going to be present in force next week. I've been to Tallahassee last week, and this week I was spared a trip up there because the physical therapy bill was not being heard in a committee, so I didn't need to make a personal appearance. But it will be heard later in the session, so I'll be sure to make return trips. I just mentioned that if you don't know, Corinne Mixon is the longtime lobbyist for FSOMA. She's been very active with legislators from one end to the other end of that building, making our concerns known. Angela works for the FAA, and she's been, again, very active in working in concert with Corinne. Hong Ji and He was with me 2 weeks ago. We were both up for committee meetings and meeting with legislators. So, you know, the opinions and concerns have been expressed. You know, that's the sort of the extent of our ability to influence future laws. Ultimately, legislators are voted and, you know, elected to make decisions on behalf of the public, and they're going to do what they think is in the public's best interest. And our job is to influence that process as best we can. Ultimately, you know, if they think that the benefits outweigh the risks of, you know, performing dry needling with minimum standards that that don't meet with our expectations, or they don't think definitions are necessary, you know, these are ultimately concerns that the legislators themselves have to wrestle with and come to terms with. It's a process, and we're finding our ways to, you know, be heard, be expressed, be at the table as best we can. And so far, the chairperson for the Health Policy Committee, Senator Harrell, has been very helpful in keeping the physical therapists negotiating with us. And she's really been working very hard to make sure we come up with some sort of common ground language that makes sense. And ultimately, you know, we can continue that process until we reach a point where we feel like either we've gone as far as we can and that our concerns are no longer being heard, or our concerns are no longer being addressed and reflected in the proposed statutory language. And at that point, it makes sense for us to just voice our concerns even louder and say, we're done. You know, we've provided you all of the input that we can, and if you're not going to act on that, then we think it's in the best interest of this bill to be either tabled or opposed. And then we have a all-out strategy to just push this bill off the legislative calendar and make it, you know, I say make it go away, but I mean is move it to a situation where it'll be re-sponsored next year, and we have an opportunity to have this discussion again. So there's a lot to chew on there, because the situation in the House is slightly different than the situation in the Senate. We have more support in the Senate than we do in the House. Ultimately, both of those bills have to survive all of their committees. And if that is the case, the Senate will decide which version it wants to make law. So, you know, we're going to continue to make sure that any opportunity we have to, you know, positively influence the outcome, we're going to do that. And FSOMA has been working, I want to say, very hard for the last 8 weeks since the session began, day and night, to find ways to develop alliances, friendships, cooperation from legislators. And we do have legislative champions out there who are concerned about the lax language, the lack of training requirements, the lack of a clear definition for dry needling. So we're not going about this all alone. We have been able to develop key legislative friends that are asking good questions and holding their counterparts, their constituents, accountable for developing a bill that makes sense, and a bill that doesn't put the public in harm or jeopardy of harm. Okay, so that's my update on the 2 bills with dry needling. You know, we'll have more as the committee weeks develop, and I'll continue to update the profession and anybody who's on the line that feels like they have a specific question or a specific concern or wants to help out in a specific way, just let me know. I'll let Ellen kind of move to the next subject if that's helpful.
I'm just going to call for questions now about the dry needling issue. You know, we've had some great success blocking them along the way. 5 years ago, we went to a board of PT meeting and then followed up with 2 different meetings where we testified and put all sorts of information before them. They decided then they couldn't make a rule. 2 years ago, they decided they could. We had to sue them. We won that case, and now they're having to go to the legislature. But this is kind of the last resort. Will PTs have to have oversight by MDs or DOs for Medicare if they are approved?
Well,
They're already approved for Medicare. If you mean to practice dry needling, it's kind of, that sounds like it's a little up in the air because of their definition of dry needling is acupuncture, and they would need to have ACOM training.
right. The way that the Medicare language came out last week, the answer to Dickie's question is does not apply, because since physical therapists, unless they're dual licensed, don't have ACOM training, dry needling is considered acupuncture, and they're not going to be allowed to perform acupuncture under the existing regulations that we just saw. Medicare would have to come out with a different proposed decision that made a change to that language to allow physical therapists to perform dry needling under a scenario where Medicare was going to pay for it.
Okay. Okay, I'm going to go to the next slide. Oh, here we are. SB 500, a bill on the title of doctor. And we've been looking at this, watching this. I'm going to let David talk about it.
All right, so we have in the House, one of the Florida legislators in the House is Dr. Mazzullo. He's a dermatologist from my neck of the woods. He sponsored the bill in the House, and Senator Harrell, the chairwoman of the Health Policy Committee, sponsored Senate Bill 500. So 309 in the House and 500 in the Senate. And this, when I read through this language, well, let me back up. Corinne Mixon made us aware of this, back in either November, December when it was first published. And what she's been working on with both Representative Mazzullo and Senator Harrell is an exemption for 457. And the discussion, even though when you look at the bill does not offer any prohibition on the use of the terms acupuncture physician or doctor of oriental medicine. Does not appear in there. Now, I don't see any other part of that language that says that that this is an exclusive list either. So there may be other things that they have in mind that are not articulated in the bill, but there's no specific prohibition for terms that are used in 457. But I think in an abundance of caution, Corinne was looking for an exemption so that we don't see this enforced in a way that may not have otherwise been intended, that did sort of scoop up and start involving the term acupuncture physician and doctor of oriental medicine. So in the discussion that she had with both Senator Harrell and with Dr. Ralph Mazzullo, they both cited that the term acupuncture physician and doctor of oriental medicine are not terms that are used in statute. The initials AP and DOM appear in statute, but they're unsupported with a definition. When you go to the rule and you look at the Board of Acupuncture rule on advertising in these terms, I think there's, a dozen or so terms that are listed A through M that include, RAC, LAC, DOM. We know what the usual terms are. And unfortunately, the way that the board had organized that list when they did it is they gave a separate designation, a separate number, if you would, on that list to acupuncture, or let's say AP and DOM, I think is items C and D. And then further down the list, it says acupuncture physician and doctor of oriental medicine, and that appears in G&H or L&M and some other place. And because they appear, again, separated in that way, there's no way for the legislators to be completely assured that there wasn't some distinction in their meaning, or that AP meant something else like, after prom, or whatever else that AP may stand for, other than acupuncture physician. And by putting them on two separate lines, they may indeed have separate meanings. So since the term acupuncture physician and doctor of oriental medicine do not appear in statute, if they were going to move against that language, they'd probably feel like they had a basis to do it. Now, I go back to what I started with saying. There's no prohibition on using the terms acupuncture physician and doctor of oriental medicine in the present language of Dr. Mazzullo's bill in either the House or Senate. I have a chance. I'm sitting with him on Tuesday morning next week, and I'll ask him directly if he's willing to offer an opinion on the use of the terms acupuncture physician and doctor of oriental medicine and how it might apply to his proposed bill, and see if I can get him to provide me an answer. And at the same time, we're still working with both him and the senator for a Chapter 457 exemption, because in our opinion, the use of the term acupuncture physician or doctor of oriental medicine is not misleading, because in both instances, it has physician has a modifier. That modifier is acupuncture. It's not just left standing all by itself. It's clear that we're talking about something other than a medical trained physician. This is an acupuncture physician. And a doctor of oriental medicine, same thing. We have oriental medicine as a modifier for the word doctor, which is not left to be interpreted as a medical doctor or any other kind of doctor. So the fact that it's long-standing language, it's been on the books more than 30 years. We have no historical use or instances of abuse in that with that language, or complaint of patients being confused or misled about that. I think we have a kind of a robust case for an exemption, and if we don't get the exemption, then maybe we can get some clarity on their intention with regard to our use of those terms going forward. Okay? Any questions on that, guys?
I want to make one point. The term primary care physician is in here. And I have heard numerous acupuncturists say that we are primary care physicians, and we are not. The term in our language, in our statute and rules, is primary care provider. So I just want to make that point, that our statute says it's a primary form of healthcare, and we are primary care providers.
Right. I think, Ellen, thank you for bringing that up. It's an excellent point. The other thing that we have to really remember and focus on when it comes to language like that is that it applies strictly to the 457 Practice Act. In other words, when we say you're a primary care provider, we're not a primary care provider under 456 or any other general occupation, pardon me, let's say this another way, like under 458. We're not a primary care practitioner in any other context other than delivering care specified in Chapter 457. And basically what they were trying to accomplish with that language years ago was making it clear that acupuncturists in Florida did not require a referral for care, as in other states. And there are examples in other states around the country where acupuncturists require a referral from a medical doctor to provide care to a patient. It's the law of the land. And so when you say that you have a primary care provider, it means that we are the primary care providers of acupuncture, moxibustion, traditional Chinese herbal formulas, Tuina, and everything that falls under our statute. And that patients do not require a referral to us for care under normal circumstances. There are instances, for example, I think there's a Medicaid plan now that's done through Optum or somebody where they require a referral from the primary care doctor after 8 visits. So there's examples of where a referral may be required, but it's not generally required as part of our practice. So when it says your primary care provider, you're a primary care provider of services and care that's specifically outlined in 457 only. Okay.
We have a question about reaching out to the FCA and asking because they are doctors of chiropractic. And again, they're doctors of chiropractic. And this doesn't say anything about doctors of chiropractic, but have you touched base with the FCA about anything?
You know, I think that Corinne and Angela have both spoken to the FCA on this, and I apologize, I don't recall their position on it. But I think it's sort of like ours. And I don't want to speak without knowing, but my take on that is that there's no strict prohibition on using doctor of chiropractic medicine listed in the statute. And usually to enforce statutory language like that, you have to demonstrate that there's some sort of specific prohibition that's being performed. And in the absence of that, it doesn't apply. That's I mean, in all the cases that I've looked at, that's typically the way that the statutory language is interpreted.
DAOMs and DACMs, all the doctoral programs, did we?
I know. See, that's the conversation I want to have with Dr. Mazzullo as well, is that, certainly we have people in the profession now who have completed doctoral programs that meet both the, the Department of Education requirements for a doctoral program, and they have both an academic and professional, licensure of doctor, and this is why I say I think that he, I'll get his answer and I'll share it with you and the profession at large. And we'll find out, how far reaching he expects the enforcement of use of these terms to go. And my thinking is that ultimately, if you found somebody's determined to have violated this act in some way, the process is going to be that the Department of Health or or the Attorney General's office is going to send a cease and desist, that somebody stopped doing whatever it is that they've been accused of doing, and that's going to be part of a regulatory case. There'd be a disciplinary hearing involved. And so somebody's going to take a closer look at what you were using, why you were using it, how you used it, and whether or not that was a breach of both first your own chapter, like how that might apply to 460 for chiropractors and 457 for us, and then how that might apply to the law in general. So I'll get some input from Dr. Mazzullo on those questions. But again, I think if somebody has an academic doctoral degree, and part of a healthcare profession, and you're a doctor, you're pretty hard pressed not to be able to advertise and illustrate your curriculum vitae that way. I just don't see how they do that. Harvey was talking to us the other night about First Amendment issues. I think that's certainly part of it, but I think even if we get off of the First Amendment, there's just some practical problems. You're a doctor of psychiatry or a doctor of behavioral psychology or something like this. There's a lot of areas where people earn a doctorate degree in the healthcare setting, and it's very hard to limit them from using that language. Okay, guys.
All right.
I think there is a little bit of a murkiness when it comes to our non-doctoral colleagues who don't carry that education background, using some of the historically accepted terms. I'm just hopeful that, again, we're not really on his radar that way, but we'll find out.
Yeah. FSOMA's kind of always had I know we've had presidents that said very clearly things, but our policy is that we're not regulators, that we think it could be risky to use the title doctor if you don't have a PhD, but we are not regulators and we have no stake in that.
Yeah, absolutely. I think, you know, there's been, I think the board did probably the best they could in terms of providing those initials and terms in rule for advertising purposes. They were probably under the same, you know, having the similar discussions years ago when they did that. But ultimately, it's still left unclear. And I think as the profession develops and matures in some ways, we'll be faced with what, you know, the physical therapist just went through this. The last time they made a change to their practice act was maybe 2 or 3 years ago when dry needling was on the table and it was removed. It was removed because what they really wanted to move forward with was separating the use of DPT, the people that had a doctoral degree in physical therapy from physical therapists who were practicing with a master's degree for many years. It's because they too are going through some of the same growing pains. So it was important enough to them that they scratched dry needling a few years ago in favor of making sure that they could better articulate who can and who cannot use the term doctor of physical therapy. And it's reserved now for those people who have completed the doctoral program.
Any other questions about this or anything else we've covered? Is there anything missing you want to know? Because we can look it up and get back to you. So,
Yeah.
all right. Well, I've got, well, I don't think we have to stay on if we're done. So thank you all for attending. I am going to post this video on our YouTube channel. And if you're coming to AcuEd Day, thank you. I actually do have a little space that's opened up if anybody else wants to come that hasn't volunteered yet. So that's next Tuesday. We treat you to dinner Monday night. We put you up in a hotel and we do a health fair in the Capitol and we lobby and talk to our legislators. So it's a great event if you've never done it. I know Dickie Walls is going to be there and he's on the call. So thank you so much and goodbye for now. All right.